Thank you for giving me this opportunity. So, before I start this talk on reconstructive surgery, Navodaya Medical College has been integral part of my life because my father has worked here in 2008 to 14. So I used to come during that time, and there has been a lot of changes. So I congratulate the management for tremendous development in this region and well advanced hospital that has come in this region serving the people. I thank management, S.R. Reddy sir, Dean, Organizing Committee of COMA for giving me this opportunity and share my knowledge. The talk I am giving today is all about stories. So, the past 15 years in which I am associated with the plastic surgery, reconstructive surgery, so we had a lot of experiences about patients, the stories, and we always tell that it's the path that is very beautiful than the destination. So I'll tell you about what experiences and how we have changed the life of a patient. And during this time, I'll be talking also about bioartificial organs, creation of a new body parts, reconstruction of new body parts with the regenerative medicine, and gender affirmative surgeries. Bonus points, I'll be telling about how you should enjoy your medical practice and achieving excellence. I know this is a post-lunch session, bit difficult to keep you all awake. So my presentations usually they are a bit of filmy. I always tell it is just like a Bollywood movie. There is happiness, there is sadness, there is suspense. There is everything involved in my presentations. It's more of a pictures, videos, and less of the words. So to just clear the myth, the most common myth is plastic surgery, we use plastic. No, we don't use plastic. Many of the times I get calls that, sir, मैं plastic लेके आऊँगा, आप कितने charge लेंगे? So we don't use plastic, and we are very much concerned about the earth. So the plastic surgery word was derived from the Greek word that is called as plastikos, that means molding. We work on the structures which can be molded, like we work on the soft tissues, muscle, bone, the bones which are soft, cartilage, we work on the nerves, we work on the arteries, skin, soft tissue. So that is the reason the word plastikos came. The plastic surgery involves the subspecialties like reconstructive surgery, cosmetic surgery, hand surgery, burns, craniofacial and all. Many of the times people feel that the plastic surgery means only the cosmetic surgery, but it's not like that. Plastic surgery means everything. The most common challenges what we come across is classically the patients come like this, the patients come with a amputated hand, the patients come with a deformities like this, they come with the absence of a ear. These are the most common challenges, but there are many other challenges. Any body wounds, diabetic foot and all, they come to us for treatment of those conditions. But how the media shows us is something like this. If plastic surgery was this easy, it would not have taken us 15 years to become a plastic surgeon. So plastic surgery is never this easy. Wow, patient's face has changed completely. So, this is a very interesting patient I had. So, absence of ear lobule, very small problem for you all. You feel what is the big deal in this? For a family, a patient of 23 years old, this is a very big deal. The patient in their childhood, when they were piercing the ear, she had an infection. So, following the infection, the ear lobule was totally destroyed. At the adult age, they were not able to find any alliance for the marriage, and you know that in our part of the Karnataka, where finding the alliance is so difficult if there is an absence of a body part. So they came to us. Then we did a reconstruction of the ear lobule. It looked something like this after the reconstruction. Almost matched the opposite side of the ear, almost similar. From the distance, conversation distance, you cannot say that it has been recreated. The patients were very happy. After 6 months, the most interesting part is after 6 months, they came back to me again with this wedding card. So the patient, once the reconstruction was done, they came back to us. They invited us for the wedding, and this is how we just don't reconstruct the ear or the part of the ear. We are reconstructing the life as well. There are many patients, something like this. They come with the avulsion of the ear, post-traumatic. This needs a reconstruction, something like this. Another part of the ear lost due to trauma, and reconstruction can be done using various types of flaps. This should be bit above the. We cannot discuss about the flap, but we can do reconstruction something like this, near normal. Completely normal we cannot do, but near normal can be done. And total loss of ear, in those cases, we stage the reconstruction and we can do the ear reconstructions. How it is done? We take the cartilage from the chest. The costal cartilage has to be taken, and we design it something like this. This is a design of the ear cartilage. The ear cartilage, we place it in various parts of the body. Like if I am doing the ear cartilage reconstruction from the auricular region, we place it in the temporal region, and we recreate the ear. In few cases, when the patient is very much affordable and they want the best of the best results, we place it in the hand. I'll show you that also. This we have placed it in the hand, and this is called as a radial forearm free flap, where we prefabricate or creation of a new ear in the hand. We recreate the ear in the hand after 3 to 6 months. Whenever the complete blood supply has been established, we take the artery, vein, nerve along with the new recreated ear from the hand, and we place it on the ear place. So this would have been the final appearance. So these are possible, but these are expensive. These are very much possible. I will show you some of the other cases where we recreated the nose, we recreated the lip and all. So ear reconstruction, very important. Like if you lose a body part, then you understand what is the importance of that body part. Various kind of accidents we get on the site of trauma, they will look extremely ugly injuries. We get something like this, and post-surgery, post-repair, we can achieve almost near normal appearance of the face. Another facial injury following road traffic accident, almost near normal, invisible scars, pre-injury. In fact, I tell them, following our plastic surgical procedures, you can get married as well, following 2 weeks. Another extensive facial injuries, facial fractures were present. We repaired all the facial fractures, fixed all the facial fractures, and this is a final appearance. Facial injury following assault. The patient had multiple assault injuries to the face, injuring his parotid duct, and we repaired all the structures. The specialty of plastic surgery is we use microscopes. So even the smallest minute structures can be repaired, and we achieve a near normal. Earlier there used to be something like you just close the skin or you just do the gross repair, but nowadays it's an anatomical repair. Even a single structure that has cut, it needs to be repaired so that we achieve a near normal appearance and near normal function. This is another upper lip following assault. Very interesting. This has been done probably 1 year back. So patient had a fight in his home with his elder brother. Elder brother bite his upper lip. So this is following the bite. What we are holding is the upper lip after his bite. This is after his bite, and he came to us something like this. So we did a reconstruction. In plastic surgery we say like should be replaced with the like. So what we did is we used a post-auricular skin from behind the ear, and we reconstructed his upper lip. And this is a reconstruction image after the reconstruction. almost near normal. Nobody can tell that he has underwent a reconstruction. Another patient who had a RTA, an engineering person, he was sutured elsewhere and there was a gross mismatch in his eyebrows. You can see that there is a gross mismatch. With this eyebrows, who would love to talk to him, or he cannot be presentable. So in these patients what we do is we have to rematch. We have to do a precision. In plastic surgery it's all about precision, precision, precision. So exactly whatever layer has cut, it needs to be repaired precisely, function has to be attained, and we use the micro sutures where the sutures are thinner than the hair and they have to be removed after 7 days. Another patient, very interesting patient, we operated this 5 years back. World is so complex that many things are beyond our control. This patient of 38-year-old, she was working in her farms, probably the farm machines where harvest has to be done. During the harvest season, there is a rotating belt. In that rotating belt, her hair entangled and pulled her entire scalp. She came to us something like this. You can see the images on the right side. She came to us something like this. And she came to us, our hospital, at 5 o'clock, and we had a OT entire day, very hectic day. After that, the hospital scenario I will tell you. The patient comes to emergency at 5 p.m. 38-year-old with the 2 kids, and initially she had a first aid at a local hospital, and we suspected a probable cervical spine injury. Obviously nobody keeps money and gets an accident, or nobody keeps money and have an injury. So nobody has the money when they come to the hospital. The scenario at 6 p.m. in the hospital premises was, we had this big list to do for her. One is to resuscitate, prepare the scalp, anesthesia of the patient, dissect the vessels, artery, vein, nerve, everything, suture the scalp, vessel anastomosis under the microscope, and needs a perfect dressing. This would have taken 8 to 10 hours. But we have to see the bigger picture. The bigger picture would have been 38-year-old will get her own scalp, which is priceless. Hairs will be natural. Body image will be maintained. Society will accept her back if we do the replant. No need of wigs. Husband and son would get a wife and a mother. Family would ever be grateful to you. And this feeling is nothing beyond anything. Like even if you become an MLA and you give someone her scalp back or life back, the feeling of this would have been any day better than being a biggest prime minister or whatever. This would have been better. So what we knew from our previous experience, that if we don't do the replant, she would have end up something like this. So at 3 p.m. we did all the anastomosis, everything was done. Once we removed the clamp, the blood started flowing inside the scalp. So the scalp entirely became pink, and we finished the surgery at 4 o'clock. We went back home. Next day morning, the scalp was perfectly alright. Now you can see the result. On the right side, this is a photo pre-injury, and on the left side, the photo is after the injury, after the replant. This is almost near normal, and she has completely regained her hair growth, everything. So this is what we can achieve with the reconstructive surgery. What was responsible for this result? Transferring the patient to the appropriate site at the appropriate time is the most important. Good resuscitation and early shifting to the operating room is very important. Good resources and infrastructure, expertise in handling the surgeries, and most important thing is post-op rehabilitation. If at the evening, if I had a long day of surgeries, and at the end of the surgeries, if I had told that no, I had done enough and I would have gone home, refuse the patient, this would have not, I would have not shown this case to you. So attitude is very important. That day, if I had told that I will not do, I would have not shown this case to you people. So attitude is very little thing that makes a big difference. So you should be very challenging, you should be keeping on pushing yourself to cross the borders. Very interesting story about James Kranz. He was a mission director of Apollo 13. You probably know about Apollo 13. This was one mission when USA was in the Cold War with Russia. During that time, Apollo 11 was the first mission, 12 was the second mission. During the second mission itself, half of the world they stopped watching the lunar missions. Apollo 13 had almost 1 lakh people watching the TV sets when it was launched, and compared to 1 crore people when Apollo 11 was launched. When Apollo 13 was launched, they could not land on the moon because they had some failures in the engine and command module. So this person, James Kranz, he was a mission director. He had a responsibility of getting 3 people, that is James Level, Fred Hayes and John Hack, bring them back to the earth safely. So this was very important for him because entire billions of dollars of money was put on them. Obviously now there is no lunar landing and they have to get them back to the home. So he used all the possible things that was present inside the rocket to make them, keep them alive for the extra 24-25 hours and then bring them back. During that time he said that failure is not an option. Failure is not at all an option. In medical science as well, for us, there is a failure is not at all an option. In plastic surgery, we say that each and every surgery is just like a space mission. We have to think that there has to be no failure at all. At least from the hospital side, from the doctor side, there has to be no failure. So the facial deglowing, these kind of facial deglowing we get, and it was completely deglowed. We had all muscles, nerves, facial nerves, artery, everything was cut, something like this, following the assault by the bull-gore injury. We repaired practically everything. All the artery, vein, nerve, everything, whatever was cut, we repaired everything, and this was the final appearance on the table immediately after surgery. And this is after 4 weeks, completely regained, completely normal sensation except for one fine scar, nothing else was visible. Very important that the patient went back home, resumed all the duties, accepted in the society normally. Many of the times we get these also, patients something with a scar alopecia, patient not having hairs on that part, very difficult to treat. In those patients, we do a reconstructive surgery. We use a flap surgical techniques and cover the non-hair bearing areas. Another patient with a scar on the forehead and tissue expanders. We use something called as, these are silicone tissue expanders. Place it below the scalp or above the bone, expand the normal skin and cover the scar. Another patient with a scar on the occipital region, expanded the in-between picture shows the expanded skin and excision of the scar. Another patient with the scar alopecia, tissue expander, normal appearance. So these patients, very important. Reconstructions are very delicate, where we combine reconstruction as well as the aesthetics. Here a family was traveling to a trip, had a road traffic accident, entire family had an accident. They were treated somewhere else where the entire family, there were nobody to take care of the entire family. So they came to us with a wound something like this on the right side. So with the exposed calvaria, the skin was completely macerated. We did a debridement and a flap cover. The final appearance was like this. After the surgery, she is after 6 months, she came to us and now she is a flight attendant in a popular airways. We do get very rare to rare cases, say preform vertis gyri. Only 8 cases have been reported in India till date. We did an excision followed by reconstruction. She is in the process of getting a tissue expanders for the skin graft. Only 8 cases, and ours was the 9th case that was reported. We do get something like this eyelid reconstructions. The patient had a post-trauma loss of an eyelid. Socket was recreated and artificial eyelid was fitted in. Many of times we do get congenital cleft palate. These patients, they have a regurgitation of the foot. For that we need to do a palatoplasty, and this is a final appearance. hyponasal voice and the regurgitation usually gets corrected following the palatoplasty. Very important you have to do is you should enjoy what you do. This is very important. If you are not liking something, you will not have any. You will not be able to do. You will not be able to be a good doctor or a good physician if you don't like what you do. So you should enjoy what you do. I enjoy doing my plastic surgery. I give 100% efforts. And another patient of a cleft lip. The patient had a cleft lip congenital. We do a repair, almost near normal appearance. Another patient with a cleft lip, near normal appearance. Post-traumatic defects, like many of the patients, they have either a road traffic accident or assault. They have a loss of the lip, lower lip, and the patient underwent a reconstruction using plastic surgical techniques. Another patient with a traumatic lip defect, with a plastic surgical repair, we reconstructed the lower lip, and this is the final appearance. This patient had electrical burns of the lower lip, destroying his lip, and we did a plastic surgical repair, and this is the final appearance. The lower images is of tumor, and following the tumor, reconstruction of the lower lip has been done. These are the craniofacial clefts. We call it as a craniofacial cleft. The patient was born with a congenital anomaly, and this is after the reconstruction. The most challenging cases are those where the art involves the surgical procedures. So we had a patient of CA of the nose, 65-year-old gentleman. The entire nose was eaten by the cancer. This was a basal cell carcinoma. So what was our challenge? The patient was hiding with a plain cloth, avoided going outside and socializing. Family entirely disowned him, and what he was expecting was a near normal appearance of the nose, and he wanted his grandchildren to play with him again. No grandchildren or no children will like to play with a broken nose, something like this, right? It is very fearful. They want to look normal. So what we did was we prefabricated the forehead flap. In these cases, what we do is we take out the ear cartilage, both sides. We take out the ear cartilage, place it in the forehead for 6 weeks. Then we prefabricate it. Then we use a forehead flap. This is a forehead flap. What has been shown inside in the image. We place it on the nose and we recreate a new nose. Extensive planning was done, and this nose was reconstructed. Reconstructive surgery. He underwent another 2 or 3 surgeries, and this is the final outcome. The patient looked better, beautiful, with a new permanent nose. He went around the town. He could now play with his grandchildren, and his dreams were very much fulfilled. Another patient with a nose reconstruction with a forehead flap, post-traumatic young person. He came to us with a loss of the nose. We reconstructed it, and this is the final appearance. Another patient with a basal cell carcinoma of the nose, reconstruction done with a forehead flap. Another patient with a post-traumatic nose defect, reconstruction done, and this is the final outcome on the left side. We had a series of patients, like many of the times we get these kind of 3 to 5 patients who are in the process of nose reconstruction. This was one of the image when I was a postgraduate. I had taken, we had 3 different age groups, different age groups where we did a reconstruction with a forehead flap in situ. Very difficult patients like hairy neighbors. This was a 24-year-old patient of hairy neighbors. Again, very difficult because the person with the hairy neighbors, again, marital issues, the people in the peer group or the society, they start teasing them. Her marital alliances were getting rejected because of this hairy neighbors. They came to us. The solution would have been the tissue expanders. So what we did was we used the tissue expanders and placed it in the scapular region. Both the side skin was expanded. In the second stage, we removed the tissue expanders and closed the area. This is the excised specimen on the right side and the after closure, and these are the results pre and post the surgery. Another patient with a meningomyelocele, they come to us for a difficult reconstruction. Sometimes there have been difficult wounds that doesn't cover easily. In those cases, we go in and help the pediatric surgeons or the neurosurgeons to close the wounds using our flap techniques. Use of latest technology is very important, and that helps us to give a better result. This was a very important patient where a sternal chondroma was seen. Entire sternum was eaten away by the chondroma. This is a CT images where you can see the chondroma has entirely destroyed the sternum. So this was the excised specimen. We reconstructed the sternum using the latest techniques, and this was a titanium plate done for the reconstruction of the sternum. And this is the coverage of the titanium plate using pectoralis major flap, and this is the final outcome. So the patient was back to the normal routine once the surgery was done and leading a normal life. We do get a lot of post-burn contractures of the neck where the patient's neglected burns. The story of this patient is very heart-touching and very unique, because this patient, husband herself has set her on fire. She sustained 50% burns and she was all alone in her home, and husband has left her to die there. What went wrong was they had a fight, and then the neighbors saw her. They brought her to the hospital. She was determined to survive. She was a very positive lady and she was determined to survive. She underwent only dressings at her local place. She came to us something like this on the right side, and we did surgeries, multiple reconstructive surgeries for her neck, for her axilla, and now she has been rehabilitated. She is doing a job in one of the private hospitals in Gulbarga now. So this is a final outcome. Not everyone is very sustained or very blessed to be always happy and not having any injuries. At present, this patient looks something like this. 6 months earlier to that, Happy Diwali was not happy for everyone, not for many. Diwali, she came to us something like this. She had a flower pot blast and facial, completely face was burnt. She came to us with a pouring pus. We did a multiple reconstructive surgeries, saying we did all the dressings, everything, and this is the final outcome. What you can see, this is what I call it as a magic. This is not a very simple. This is a magic, and the magic keeps continuing. Another patient with the oil spilled on the face. Another patient, right side, left side, you can see that the patient had dipped his hand inside the oil, burning oil, and multiple procedures were done, and near normal appearance. Hardly anybody can say that he had a burns on his hand. So we do get many of the times neglected burns contracture, axillary contractures. This patient had a severe axillary contracture, not able to do any of his routine activities, the basic hygiene activities of his body. So we did a reconstruction, entire axilla was released, and this is a normal range of movements. Initially, before the surgery, he had only the 15 degrees of movements. Now he is having the normal complete range of movements. We do get many of the times, many of the vascular malformations, like in his forearm, he had a very big vascular malformation, plenty of vessels that was having a multiple feeders from the bone, artery, vein, everywhere. Potentially very difficult, because he could have died till the last blood, but reconstruction was done, complete excision was done, and this is the final appearance after the suture removal. We do get these kind of abdominal hernias, 5 times operated before this, multiple to 4 times operated for hernia. Before that, she underwent abdominal hysterectomy for fibroid. So we did a reconstruction. Hernial sac can be seen. Mesh was placed, and this is the final appearance. You can see here. This is the final appearance, and patient is very happy. This is what can be achieved if the patient has been treated properly. Thigh-plasty, like this is this patient had a lipodystrophy of the both the thighs. The thighs were disproportionately bigger compared to his body. We did a liposuction, along with the excision of the skin and achieving a near normal appearance of the thighs. So we do get unique problems, very unique problems. Children, you know, right? They don't sit, they put their hands in all the places. This child had put her finger inside the idli utensil. So the finger got stuck inside that, and the distal part of the finger was edematous. They tried removing inside the home using soap, using oil, everything, whatever was available. They tried to remove everything. Very unique problem. They came to us on a Sunday evening. They said that there is an emergency and I had to rush in there. So what we did was, under anesthesia, we removed the utensil and patient went happy with, to the home. So we always see about only the success, right? You see that surgeon is very successful, that actor is successful. We don't see the background, how much work they do, or we don't see the failures. So I had a failure story. What makes me work for more longer hours? What makes me achieve better? And I analyzed my surgeries after each and every surgery. So I had one thumb amputation in my post-graduation days, where the patient came, young person, 28 years old probably. He had a thumb amputation. So I attempted 8 hours. I attempted for a thumb replant, and I had a failure. So I went back and I could not sleep for 2 or 3 days, because in a complete hand, the thumb plays a 50% role. The function of the hand, if you consider 100%, 50% is done by the thumb, and the rest 50% is done by the 4 fingers. So thumb is that important. So I went and I thought what way we went wrong. So I'll tell you about the next story. This patient was run over by a 25-ton truck on his right upper leg. If you know who is he, you will feel that very bad things happen with the people, but at the end he is able to lead a normal life. So he came to us at 7 o'clock in the evening. This was his clinical picture. The entire artery, vein, nerve, everything, axillary artery, vein, nerve, everything was crushed, and we did a reconstruction. This is a artery, what you can see, vein, nerve, everything was reconstructed. You can see the pulsations there. The beside bluish thing is a vein, and the long slender thing is a nerve. All have been reconstructed. The crushed things were removed, everything. So who is he actually? He is a Bharatanatyam dancer. This was the pre-injury photo. We felt very bad in the afternoon. Even I don't ask anyone. Once I go to emergency, I just see what is the injury, what should I do, what should be the next plan. I was not knowing that he is a Bharatanatyam dancer. So we did a reconstruction. This was an immediate on-table appearance, and post-surgical, the oxygen saturation was 100%, normal blood flowing, everything was normal. This person was coming to the hospital itself, and his mother was hospitalized. He was getting food for his mother. During that time, he met with the accident, and again he came to the same hospital. He was just lying beside his mother, not knowing that his mother is also comatose and he is also comatose. After 7 days, the real problem started. All the muscles that were crushed, they started releasing myoglobin. So he had a AKI, acute kidney injury was there. He had to undergo dialysis, and at 7 days we had 2 options: either to save his life or we have to save his limb. That's a trial. If we keep the limb, we may have to lose the life. So after all the deliberations and discussions, we decided to take out his limb. This was the image after taking out the limb. We had his prosthesis, where you can see the sensors are placed and the prosthesis makes the movements. Another patient with a sharp 4-wheel vehicle accident, injuring his popliteal vessels. We used a saphenous vein graft. This is a saphenous vein graft to reconstruct the popliteal artery vein, and this is a final after repair, and this is, you can see, after the closure, 100% saturation has been maintained. most common injuries I get is fingertips as well. Very important. You in our community or in our places, there is one important thing. If somebody has a finger injury, they feel difficult to find an alliance. And there's one more unique problem is in one community, puja community, they don't allow them to do any pujas in the temples. They don't allow. And even many of the communities, they don't allow them to do home pujas as well. So this patient has a amputation of the fingertip, something like this. I get many of the patients, weekly we get 3 to 5 patients where children keep their fingers inside the door and somebody else close it, injuring their fingertips. We created lot of awareness videos, and we have provided many of the times the door protectors as well. But still we keep getting these kind of fingertip injuries. In these cases, what can be done is we do a reconstruction. What reconstruction? We do something called as graft reposition flap, where we use the bone of the amputated part, replace it back along with the bone, nail and nail bed, and we do a cross finger flap. That is a flap taken from the opposite side finger, and this is the final appearance, and this is a normal function. Nobody can say that other than color that this patient had an amputation of the finger. This is a precious hand. I say it as a precious hand because for him this was the most precious moment, and he wanted, this was the only lone earner of the family. This was a 41-year-old gentleman who was working in a farms, and accidentally he had a cut off his hand like this. He came to us with a hand in the left hand, and the cut hand he was himself carrying that in a plastic carry bag. He came to us. So this was the amputation and this was the stump. We did a reconstruction, replantation of the hand, and this was the patient at the 3 weeks. He's absolutely doing very well. He's on aggressive physiotherapy. He needed small surgeries that has been done, and now he has been rehabilitated with the office job. Very important, like reaching the correct center, reaching correct time, how to carry the hand. That's all very important. Another patient, there was a turn of tide. We had a 60-year-old gentleman who came to meet his grandson on a Sunday morning, but fate has other plans. He came under the train, cutting his forearm. The challenge for us was to replant, to place that back to his body. So he was taken to the local hospital, then he was shifted to our hospital. So we did a reconstruction. We joined all the cut structures, all artery, vein, nerve, muscle, everything, bone, everything was joined meticulously, and it took almost 10 hours, and this was the final appearance. He is under the physiotherapy, and he will, with the due course of time, he will further improve. Any day, having a own hand is better than having a prosthesis hand, because I'll tell you about the cons and pros of prosthetic hand as well. Another challenge, multiple times I told you, we get a amputation of the fingers. We can do a replant along with the abdominal flap, and this is the final outcome. We do even get the cancer patients where we have to reconstruct the removed cancer part. So this patient had a CA of the buccal mucosa. We did a free fibula, and entire mandible was reconstructed using the fibular bone. Now, reconstruction of the chest, very few slides I have. There is like losing a part of the body is same as losing a part of the arm or hand. So I always tell, if you have somebody has a CA breast, they has to be offered CA breast reconstruction. So what we do is this is a preoperative image. So there is something called as fully expanded implants, and we have kept the implant, the silicone implant inside the breast, and areolar reconstruction has been done. So this is an implant placed below the muscle, and now we have 3 to 4 varieties, like immediate implant based reconstruction, or it can be delayed. Now in this picture you can see that the patient had a CA breast, mastectomy was done, and immediately the implant was placed and reconstruction was done. Very famous figure, she had a BRCA gene positive in her family, so she underwent a double mastectomy with an implant-based reconstruction immediately, so she could resume her all the commitments. In some patients, we do something called as latissimus dorsi flap, where the muscle behind the chest or the scapular region, we take that muscle, we reconstruct the breast using that muscle. A patient of breast cancer reconstructed using the LD flap. Another patient where the patient was 38-year-old, she was living all years, 7 years like this. She was feeling less feminine, less feminine. So we did something called a cramp flap. We take out the lower abdomen. You can see lax lower abdomen, and we did a breast reconstruction. And this was the final outcome. Who doesn't want abdomen like this? Like you get a breast reconstruction as well as a fitter abdomen. Who doesn't like that? Obviously, everyone likes that, right? So this was the final outcome of the abdomen. The suture line goes inside the panty line. So very confident, very. So this was the final outcome, pre and post surgery. That can be converted into a free flap as well. Free flap means we take out the flap along with the artery vein nerve and reconnect on the chest vessels only. So another patient with a CA breast, absence of the breast on the left side, we use a cramp flap, free flap was done, and this is a post-surgical outcome. There is something called as that nowadays you can see because of the Instagram, Facebook, social media, everything, the people doesn't want a cut on their tummy as well, lower part of the tummy. In those people, we do something called as S-gap flap, that is a superior gluteal artery flap, where we take out the flap from the gluteal region and reconstruct the breast. So what is the future of the reconstruction? Robotic harvest that is going on already in few of the places. Artificial dermis, that's the acellular dermal matrix, has been used to cover the implant. Lymphovenous anastomosis is routinely done in most of the centers. Stacked flaps. Stacked flap means small flaps along with the areolar reconstruction are being done. This is a harvest of the LD using a robot. This is a harvested LD through the robot, and reconstruction done using a harvest of the robot. So I commonly get a lot of patients with the gynecomastia. These are the images of gynecomastia, grade 3, pre and post surgical daycare procedures. Another patient with the gynecomastia, reconstruction done using the, absolutely you cannot see any scars. Anybody can find out scars? Absolutely no, because the scars are placed in such a position that it should not be seen on the chest even if you are bare. So many of the times we get challenges something like this: totally crushed foot, completely mangled, crushed over. We have to do a reconstruction and then achieve a result something like this. Finally, he was able to walk after 3 months of plastic surgical procedures. This lady was a 24-year-old MNC employee who was run over by a bus, BMC bus, and they were shifted to the hospital. She came to us, we did a debridement, and the final appearance was something like this. Now, this is not the end of the result. We need to do something to have a similar near normal output. So we used the LD muscle. The muscle was taken from the back along with the artery vein nerve and covered on the foot, and this was the final result. Almost near normal, able to walk, able to do all the routine activities, and she got married. She sent us her wedding card. Now, the important thing about the plastic surgery is not all the time we will be able to get the own tissues. In those cases, we go for a regenerative surgery or we go for a tissue engineering. The tissue loss, chronic diseases, end organ failures, social economic strain, they afflict individuals and society. Currently, the treatment strategies, they are on the extracorporeal devices like dialysis, operative, allograft, transplants, and free tissue transfers. In India itself, we have somewhere around a requirement of 25 to 30,000 of liver transplants that are needed. The patients are that much, but we are hardly able to do around 10 to 15,000 of liver transplants, and liver failures are 10 to 15,000, but hardly 5 to 10 liver heart transplants happen in India. So our basic idea of organ failure, what can be done is artificial organs. So why we need artificial organs is because of the shortage of the organs. They can act as natural organs when the organ fails, and some devices they help in assistance and replace the original organ. The meantime, till you receive the final treatment, that can act as a managing the patients to provide the transplantation. So we use commonly artificial skin, that is dermal matrix. There are many scientific research that is going on in the various labs that we can match the skin, but skin cannot be matched. The problem with the skin is it has more antigenicity, so it gets rejected. Even we can't use the skin from the other person, it gets rejected very easily. So nowadays what we get is a integra. Integra is a dermal matrix that can be used, and we are using it commonly. These are the wounds where you can see the tendon has been exposed, covered with the dermal matrix. On that we use a split thickness skin graft to achieve a near normal. These are the dermal matrix that are available commercially and have been routinely used. Dialysis is another where if the kidney fails, we use dialysis till the patient is taken up for the transplant. They keep the safe levels of the chemicals in the body and helps to control the blood pressure, done in the hospital setups, and there are some home dialysis units as well. So obviously there are two types of hemodialysis, peritoneal dialysis, and this is a dialysis machine. Many a times artificial pancreas has come for the type 1 diabetes, takes over the patient's disease, and this itself monitors the blood sugars, delivers the insulin as much as required. Many of the times I do treat diabetic foot. In those patients we implant the injector inside the body. It measures the blood glucose levels and gives the insulin as and when required. So a lot of research has been going on in this regard, and last 20 years these are the instruments. You can see the continuous glucose sensor is there, and it gives the sensory response towards the instrument, and it pumps insulin, it pumps inside the body. So artificial heart, it provides a mechanical circulatory support used for severe heart failures. Heart failures is a condition where the patient's heart doesn't give enough blood supply to the body needs, and it causes coronary disease, cardiomyopathy, heart attack, and congenital heart problems. Basically there are two types of heart, artificial hearts, VAD and TAH. So ventricular assisted device, and this doesn't replace the heart. It works along with the heart. It is a basically mechanical pump and surgically implanted next to the heart. Runs on an external battery pack that you have to carry constantly to keep your heart pumping the blood. And this has to be attached to the left ventricle and to the aorta. It works by helping the heart pump blood from the left ventricle into the aorta. The blood circulates through the body, and this keeps the patient moving around, and this is a meanwhile till the patient gets a permanent heart. This is a temporary procedure, and these are the devices. Another device is a total artificial heart, very small device. They are connected inside and have a outside power source. They run a chest tube within the heart. So these are the devices you can see here. These are the devices. So artificial kidney, again, these are very much experimental stages. Two-stage system, nanoscale filters and remove the toxin from the blood. These uses the homofilter to remove the toxin from the blood. They are engineered, and they look something like this. They look something like this, and used in the patients of a kidney failure. Now, recently there was a very famous news that was coming. It has become viral. Liver donor died because of sepsis. Archana Kamath, probably everyone has read about this lady, 33-year-old. She donated her part of the liver to her aunt, and she died following the liver donation. So liver donation has been very less in, and more of live liver donation. So here what we do is artificial liver decellularization, process of removing the cells. The structural cells has to be removed, leaving the architecture, original architecture, what it is there, it has to be retained. The matrix of protein remain behind to hold the liver shape. The liver shape has to be maintained, and we use hepatocytes, tissue engineering hepatocytes, and recreate the entire liver. So I will talking about the tissue engineering. I will tell you about how liver has to be recreated. So artificial lung has been done. This has been tested in the pigs. The blood flows through the inlet and gives a fresh oxygenated blood to the outlet. These are again in the experimental stages going on. Bovine experiments have been done. Our interesting topic is hand transplant. So India is very much capable of doing a hand transplant that was achieved only by few of the Western countries before 2015. Now we have done almost 15 to 20 cases of hand transplant, and in due course there is a face transplant that's going to happen in India. So this patient was a second hand transplant girl, probably from Karnataka itself. She had a Volvo bus accident, crushed her both hands. So she received a both hand transplant from a male, that too above elbow, first time in Asia. So why this is very important? Prosthesis is not a good thing, because prosthesis, it's a very much challenging with the prosthesis to have a body hygiene activities, body grooming. There is no sensory feedback from the prosthesis. Visual control is very much necessary. Like if I lift a baby and if I move my eyes that side, I'll be crushing the baby. So it's very important that we have a tactile sensory feedback from the prosthesis back to our brain to hold a. If I have to hold this water bottle, I have to see this. If I don't see, I'll crush this. And with the prosthesis, there is a very long learning curve, and prosthesis are really expensive. But the advantages of prosthesis are they can be fitted earliest, no immunosuppression has been required, and you can return to the normal activities at the earliest. What is the ideal thing for loss of an organ or a loss of a body part? The ideal thing would have been to recreate the entire organ in a corporeal devices, biocompatible, easily integrated into the patient anatomy. This is the most ideal scenario. But it's not so easy, right? It's not so easy. Our mind keeps creating ideas. We are the people where our minds are made such a like that we hardly store any memories, or we are not a storage building hard drives. Our brains create memories. It's always creating new ideas, new innovations. So for this, tissue engineering came up. The crazy people, they started doing new experiments. So there is a in tissue engineering, what we do is there is a we have these 3D printers where we use a spheres. Spheres means we have a structure on which we implant the cells and create organs. New organs have been created. The multiple organ manufacturing has been done, and there has been multiple experiments going on, but no human trials have been started as of now. Pluripotent cells have been used to generate the functional pancreas, kidneys in disabled mice. Synthesis of artificial blood vessels are in experimental stages. In our plastic surgery, we are trying to do a ear cartilage. Human trials are in the process of legal hassles. Now, why our science have been increasing so fast is because when I was doing my MS, during that time there was a saying that the science used to get doubled every 4 years. Probably 2005 to 10, the science used to get doubled every 5 to 10 years. Due to advent of internet, connectivity, social media, the science is getting doubled in every 12 months. So, being updated is very, very important. If you lag behind for 1 year, if you don't learn about any recent advances, you are lagging behind almost 12 months. So regenerative medicine, we use natural regenerative properties of the cells to repair the endogenous body parts. So what we commonly do is I do a PRP for the hair, I do PRP for the facial regeneration. Here the growth factors present in the blood itself, we use them to recreate the normal cells like hair follicle or regenerate the facial. Various places like body facial regeneration, for the arthritis of the knee, for the balding scalp, this can be done. Regenerative medicine and tissue engineering, the advantages are there is no risk of immunosuppression. It reduces the dependency on the other organs, but this is in a very much of experimental stages. Continued research is needed, and there are lot of ethical issues in this regenerative medicine and tissue engineering. Coming to the last and the final topic given to me is gender affirmative or transgenders. I routinely do many of the transgenders. Our center is a transgender friendly center where yearly we do around 10 to 12 cases of transgender male to female and female to male. So what is GID? These patients have a gender identity disorder. You might be feeling I haven't seen any patients of gender, they roam around us, but you will not be knowing that the patient has this problem. So is a desire to be other sex, that the person desires, the patient, his genotype is entirely female and he desires to be as a male. So that desire itself makes it as a gender identity disorder. In adults, disturbances are manifested as preoccupation of getting rid of primary or secondary sexual characters. So there are many criteria. There is a WART criteria where it says that transsexual identity should be persistently for 2 years before we take for surgery, and there should not be any symptoms of other psychiatric disorders like schizophrenia. It should not be associated with chromosomal abnormalities like Klinefelter's or Down syndrome. Any other syndrome should not be there. And the patient should be staying in the opposite gender for at least 1 year. So there are so many criteria that we have to follow before doing transgender. For girls, they have to be dressed up like a male. They have to follow all the routine hormonal analysis, hormonal supplements has to be taken. For boys as well, they have to be staying as a girl. They have to dress like that. They have to be cross-dressing, we'll give the hormonal supplements to them, and there has to be two psychiatrists. They have to give a individual opinion that the patient is fit for undergoing a surgery. So before taking up surgery, surgery is deferred till 1 year of starting the hormonal treatment and at least 2 years after the psychosocial consultation. In female to male, the surgeries what we do is mastectomy, hysterectomy and oophorectomy. We try to develop an aesthetic phallus. Testicle reconstruction with the normal appearing scrotum has to be done. Maintain the erroneous sensitivity. Development of the phallus capable of sexual penetration and ability to void or pass the urine in a standing position. So I just wanted to show few ideas. So that's why we have kept the images in the black and white. This is a non-surgical, like non-microscopic radial forearm free flap where we use the skin from the forearm, reconstructed the phallus, that is penis has been reconstructed, and this is the final outcome. Totally functional penis but doesn't have erection. For that we have to use an implant. Another patient with a facial feminization, the patient's face in the males, they have a broader cheeks, broader forehead, the prominence of the forehead. So in those cases we do something called as facial feminization surgery, series of surgeries, and we recreate the female appearance. In patients with a male to female, we recreate the genitals, that is the penis has to be taken out and we recreate using the penile skin, and vagina has to be recreated along with the clitoris. In male to female, we do a breast augmentation, we use a silicone implant, daycare procedure, morning we operate and we send them back home. Transgender, another patient with a male to female, this is following hormonal. There is some amount of breast gland that enlarges, and after the implant, this is the final appearance. This is another patient with a female to male. When I did my first mastectomy in a female to male, because we as a surgeons, we don't excise the normal breast tissue or normal tissue. So when I was doing my first mastectomy in a transgender, so I was very nervous because I am removing the normal breast tissue from a normal patient. So I felt very guilty and I expressed that to my patient. So the patient said that if I don't undergo this patient, I am going to commit suicide. That is the level of their psychological trauma they had undergone being in opposite sex. So gender identity disorder is a very serious disorder, needs to be addressed. In plastic surgery or in medical science, there is a lot of hope, there is a lot of science advances that has been going on. The face transplant has taken up very good and reconstructed many of the patients' life. You can see the evolution of the face transplants. Initial years, the patients had a very odd, very rough appearances of the face. Now, almost near normal. You can see right side and the left side images, pre and post face surgical transplants, near normal appearances. We are not just reconstructing the patient's life, we are entire family that has been reconstructed. This is the latest 2015 face transplant, almost near normal appearance of the face. So, my sincere advice to the younger generation is, people who really close to me, they know that I don't sit idle. Probably I keep doing something. We have to work harder, we have to work smarter. And I strongly believe in Steve Jobs' words. We have to stay hungry and stay foolish to achieve better in the life. If I have 10 more minutes, or I'm done, 5 minutes, I can tell you one small story. If everybody is interested, I can tell you one small story. Want to listen? Chairman, I can use time. So, very interesting story. Why ultimate power I have put this. We are just instruments in the hands of God. I strongly believe Mahabharata. I'm very. If anybody is sleeping, please get up. This very interesting story. So in Mahabharata, Arjun wanted to do puja of Krishna. So he went to forest to collect some of the flowers. In the forest, Hanuman is eternal and he was sleeping in the forest, just as a simple monkey. So he stepped on the monkey's tail and Hanuman caught up. So Hanuman was guarding that part of the forest. So Arjun went and plucked the flowers. So Hanuman asked, why you are plucking the forest? I am guarding this, you cannot take. So Arjun said, I am doing the puja of my god Krishna, so I want flowers, so I am picking them. No, you have to take the permission of me before you pluck. How can you take? You are a chore, your god is also thief, you cannot do like this. So Arjun got angry and he said, how can you say my god chore, how can you say him a theft? Your god is not very great. I saw your Ram, he made monkeys, all the animals to build one bridge, and he couldn't do that. So if I was at that time, I would have just shot one arrow and I would have built one bridge that would have taken you all to the Lanka and brought the Sita back to the India. So listening to this, Hanuman got very angry and he said, this cannot be practically possible because there are thousands of monkeys and other animals who have to go from India to the Sri Lanka and getting back. That arrow bridge cannot withhold the weightage of all the monkeys, all the archery, everything. It cannot hold. So Arjun said, I can build a bridge which can hold all the monkeys. Then Hanuman said, you build a bridge which can hold only one monkey. If I step and if it doesn't break, then you can take whatever you want. Or if you make a bridge and if it fails, then what you will do? Arjun said, I am a Kshatriya, I am a man of words. So if it breaks, then I will take self-immolation, like I will burn myself. So Arjun said, okay. Hanuman said, okay. So Arjun, he fired one arrow and he built one bridge on the lake. So Hanuman, he took a huge, very huge avatar where the entire sun got covered. Looking at that Arjun's avatar, Hanuman's avatar, Arjun said, I am gone today. This bridge is going to go today into the hell. So Hanuman kept one step and the bridge broke completely. Now Hanuman said, where is the maker of the bridge? Where are you? So Arjun said, I am here only. I am sorry, I failed miserably. So I will die by immolation. I will fire. I will start finding the woods and I will live. Now Hanuman felt very guilty of himself that Arjun, who is the greatest archer, he is dying and this person has a huge life ahead of his life. So Hanuman himself in that time he prayed for Krishna that he should come and save this situation. So Krishna appeared as a Brahman and during that time he saw the Arjun and he said, what are you doing, Arjun? So Arjun said, no, we had a bet and during that time I lost the bet. So I am immolating myself by fire. So Arjun said, I will die now. So Krishna said, okay, you die immediately. But what is the exact bet? Who is the judge here? So Arjun said, I had said that I will make a bridge with an arrow and monkey will stand on that. Monkey stood and the bridge fell off. Now, he said, you both have decided, you both had a bet. Who is the judge here? Now you make the bridge again. I will do the judgment and we will decide who has lost and who has won. Now Arjun again he made a bridge. Hanuman again he made another huge avatar. Now what happened was Krishna he became a kavach rose. He went below the bridge. He stood. He balanced the bridge. The bridge didn't break once the Hanuman kept his foot on the bridge. Now Hanuman said, you have won, Arjun have won, now you can ask whatever you want. So the Krishna appeared and he said, don't ask now, we will keep this gift for yourself in the future. So during Mahabharat war, it is said that the Kapidwaj, the chariot of the Arjun is called as Kapidwaj, is because the Hanuman was sitting on the chariot and during the war, the entire war, if you know Karna and Arjuna are the greatest warriors, once the Arjun beats an arrow to the Karna, his chariot used to go 10 to 15 feet behind. And once the Karna was hitting the arrow to the Arjun's chariot, it used to go 1 or 2 feet. He used to say, Arjun used to say, see sir, because Karna is also equally great warrior, my chariot is not going behind. Krishna said, no, don't say because of the Karna's incapability. It is because somebody is above you. Once the war was over, once the Bhishma was dead, everyone dead, Krishna said, Arjun, you first get down. Then he indicated the Hanuman to get down. The entire chariot was blasted. The entire chariot had a fire. So seeing at this, Arjuna asked, why this had a fire? So Krishna said, your chariot had a fire on the first arrow of the Karna. Your chariot had completely destroyed. It was because of the Hanuman that chariot was maintained till the end of the war. So my important thing here, what I wanted to convey is, whenever we operate or whenever we do good things, it's not just our own efforts. There is some ultimate power that's guiding us, that's keeping us alive, that's keeping us motivated. We are just the instruments of the hand, and that's it. This is about reconstructive surgery, gender affirmative surgery, and new organ creation. Thank you for giving me an opportunity and listening questions. I thank Anand sir for the patient hearing. Thank you, Madhya ma'am, for giving me an opportunity.